Welcome to our webinar titled Preparing for Transplant. Thank you for joining us. My name is Lee Clark, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible you may lose your connection during the program. If you are unable to view the web program online, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit your question or comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our expert speaker today is Constandina Herbert, who is a nursing supervisor in the Blood and Marrow Transplant Clinic at Seattle Cancer Care Alliance. She works with patients and families and caregivers as they navigate the transplant process. It's my extreme pleasure to welcome Costa today. Thank you so much for joining us.
Thank you so much for having me. Happy Friday, everyone. Hope everyone's doing well. Wish we could be meeting in person, and hopefully one day we'll all get back there. As Lee mentioned, I am a blood and marrow transplant nurse. I'm most recently a nursing supervisor. Previously to that, I have worked both inpatient and outpatient and cared for transplant patients my entire career. So I certainly wouldn't say that I am an expert by any means, because I'm learning new things every day. But I think I have a fair amount of information to pass on to everyone as they're going through this incredibly uncertain time in their life. So today we'll talk a little bit about the science behind allogeneic blood or marrow transplant, which may be a term that you've already started to hear about. Define what to expect before, during, and after the transplant. Offer tips on how to prepare for your transplant. We're going to provide you with resources for further support. And then, as Lee mentioned, it's going to be followed by a question and answer period. Now, as I touched on briefly, the time we're living in right now contains a fair amount of uncertainty for everybody, but then you add a cancer diagnosis into it, and it's really important to understand this may be a time with lots of feelings of anxiety, depression, just fear of the unknown, and just realize that that is completely normal. And I would say this is what most patients experience at some point. So before we get too far into it, and we won't get too far into this slide because it's a little bit high level, but in general, this is your stem cell cascade. So if you've been diagnosed with a form of a blood cancer, aplastic anemia, MDS, leukemia, that all originates from somewhere along this stem cell cascade. So it starts with the kind of the baby stem cell and matures into 3 different lines. And those lines become your platelets, your red blood cells, and then your white blood cells. So depending on where on the cascade this happened, depends on what type of issues you will have and what type of diagnosis. So common terminology, you'll hear me talk a little bit about allogeneic stem cell transplant. So that is the process of replacing unhealthy blood-making cells with healthy cells from a donor. Stem cells are found in the peripheral blood or in the middle of the bones, also known as the bone marrow. They mature into, as we talked about the last slide, red blood cells, white blood cells, and platelets. And our donor sources for transplant can include a related donor, an unrelated donor, umbilical cord, or bone marrow. It also, how closely you are matched depends on your source. For instance, umbilical cord, we do not need to match as closely because those cells, they're baby cells, right? Because they've been harvested at the time of birth. So they're not as differentiated, which means they don't have as many markers, which means most people who may not have a related or unrelated match out there, we can find a cord blood unit for. And then graft versus host disease. It is your immune system. What happens is the cells that we transplant in your system, they recognize your body as foreign and start attacking your body. So that's just kind of a brief overview. So as we touched on a little bit, these sources for transplant can be stem cells, which is the most common use, which are collected through an apheresis procedure, bone marrow, which is a surgical procedure, umbilical cord blood, which is collected at the time of delivery, and then related or unrelated and matched or mismatched. Obviously, our preference is always matched, but if people do not have a viable match, we will look at a mismatch if needed. So what is being matched when I say mismatched or matched? It's something called human leukocyte antigen, and they are the protein or your markers that your immune system uses to identify self from non-self, and they live on the surface of your cell. So you inherit half from a biological mother and half from a biological father, and they're inherited in groups, which explains why people with extremely diverse ethnic background, it's oftentimes harder to find them a match. So this is a common question I get working in this field when people are starting the process is, what do the donor and the recipient, if they're unrelated, know about each other? There's quite a bit of confidentiality surrounding this. And so it's really just bare bones. So the recipient is informed of the donor's age and sex and vague geographic location. And the donor knows about the recipient's diagnosis, their age, if they were a child or an adult, and about the chance of survival with and without a transplant. We also get asked the question, can I reach out to my donor to thank them, to get to know them, et cetera? And if the donor at the time of donation has allowed their consent, after 1 year has passed, they are allowed to reach out to the donor. And there's that 1 year delay so that there's not a conflict of interest with persuasion or anything like that with the patient's care. So after you've learned that transplant is the best option for you, I would say the first thing to do is do your research. So there may be a transplant center near you. There may be several near you. So a good place to start is the Be the Match website. You can look at transplant center outcomes, and it also has a list of diseases transplanted and other transplant cases per center. So it may be that one center does a significantly larger amount of leukemia transplants. Another center happens to do more PNH, whatever the case is. So it's really a wealth of information. So the first step in preparing is, sorry, one moment, my screen on my side's a little bit frozen. The first step is to discuss with your oncologist and the transplant center closest to you, and if there's any need to relocate. Your transplant center may not be the best option for you depending on your disease or donor source. You may want to assess your financial coverage and resources. It may be that your insurance covers you at a certain center, but not others. It may be if you have 3 near you, but one is within 30 minutes and the other 2 are more than an hour away, that will, the one closest to you is the one you select, because most transplant centers do require that patients live within 30 minutes of their center for safety reasons. You're going to want to identify a caregiver, and that would be someone who will be with you the entire time through the transplant. Make decisions about your hair. So before people lose their hair with chemotherapy is really the best time to think about, do they want to purchase a wig? Do they want to cut it short? It's really hard to match your natural hair color if you're waiting until your hair is already gone. So I would say think about these things ahead of time. Some of our younger patients or people that may not be done completing their family may want to think about fertility preservation. Most oncologists and transplant centers are pretty great about bringing this up, but just make sure that it is on your radar as well. So it may be necessary to relocate. And that, as you can imagine, can be a hardship because people then are usually maintaining 2 households, paying rent somewhere locally near the transplant center, and then whatever mortgage or rent they're paying back at home. They may find if they're leaving a house back at home, they may need to delegate things like yard work, keeping up on the house, making sure someone's just keeping an eye on it. See if your insurance covers local housing. Unfortunately, most of them don't, but once in a while, usually Medicaid covers housing, and there's a couple other plans I've seen that cover housing, but for the most part, it is the responsibility of the patient. If you still have pets or children at home, it's decisions about what will happen with them. Will the children come with you? If so, if they're in school, will you try to find a school locally? Will they stay back home with a loved one? Pets generally aren't recommended to be around you during your transplant if you're moving close to a center. If you're already at home and staying there and have pets, then that's okay. We just have usually different precautions in place. And just keep in mind that there will be, as if you are relocating, there will be a separation from the support network you normally have. So patients going through transplant often find keeping up with all their loved ones and how their care is and how their transplant is extremely exhausting. So what I tell people to do is find one single point of contact. So is this a role your spouse could do if you have a spouse, or your caregiver, or a child, someone in your life that can help disseminate information? There are also websites people can use like Caring Bridge or carepages.com where you could post, and that way it's less overwhelming for people. So this caregiver role is one that is a very large role. They are the patient's advocate. They help them get to their appointments. They help keep track of what was said in clinic. They help keep track of how the patient is eating and drinking and taking their pills on time. On the pill topic, they help make sure that the patient has an understanding about their medications and they're taking things appropriately. They should remain with the patient most of the time for safety and help prepare food and clean living space in accordance with the guidelines. There are extra kind of cleaning, infection prevention guidelines we usually give patients. And a really important thing is that the caregiver knows how to care for you and themselves. It doesn't do us a lot of good if the caregiver is overwhelmed and exhausted and not feeling well. So they have to try to find a space to take care of themselves as well. So this is just kind of a reminder because it's a very humbling experience to be a caregiver, especially if people have never been a caregiver before. It's also humbling for people to receive care. That's oftentimes a hard position for people to be in, especially if they've never required care. So at some point, all of us will be either a caregiver or who will need a caregiver or all of the above. So just keep that in mind and give yourself and caregivers the extra space to kind of go through this difficult time. Okay, so one of the major things that people are educated on before they go to transplant is extra infection prevention measures. And this is because in order to administer the new stem cells, we completely or cut down significantly people's immune systems. So we do have to take extra precautions. So at our center, and again, this is my center's recommendation, so these may vary a little bit from center to center, but our recommendation is we have people clean common areas with the water and bleach solution, no plants, flowers, no gardening, no exposure to construction. And those plants and construction is due to the risk of fungus that lives in the soil that a normal healthy person, it wouldn't make them ill, but with a decreased immune system could make people quite ill. Tap water. So if people live on a well, it may not be safe for them to drink. Our well water patients, they have to boil it before they drink it, or they have to drink bottled water. Avoiding any pet duties if you are living already with a pet. So not cleaning your litter boxes, not cleaning up after any dogs. No humidifiers. As you can imagine, they are a breeding ground for waterborne bacteria. Filling the house with food that is safe for you to eat. Most centers do have some amount of food that they have you avoid when you're going through a transplant. But again, that does vary from what I've heard between centers as well. Most people right now are already doing this last one, which is avoiding crowds or anyone who looks sick, and doing social distancing before it was the cool thing to do. It seems really silly to talk about hand washing, but it really is important to touch on because it is our #1 defense against infection. Excuse me. So this is you and everyone around you. It's making sure that you're scrubbing all the surfaces of your hands, your nails, the back of your hands for at least 20 seconds, or using hand sanitizer, and making sure this is happening before and after eating and after using the restroom. Another infection prevention measure is avoiding cigarettes, vaping, and any form of marijuana. I have patients ask me, does that include edibles? Does that include baked goods? And yes, it does. You would actually have to bake goods at about 600 degrees Fahrenheit in order to kill the mold spores that are present in marijuana leaves. So that's the reason that centers advise against marijuana in any form. Cigarettes, same thing. It can cause significant fungal infections in addition to the lung damage. And lung damage can be really difficult to deal with transplant. That can be hard on your lungs. Then alcohol, even though there's no risk of infection there, it can harm your liver and interfere with important medications. So depending on the center you go to, you will already be on the team you're going to be on for your transplant, or you will go to a different team. In our center, we have teams that only take care of transplant patients. So what that means is you arrive to the team, you're introduced to the team structure, how to access this team 24 hours a day if any issues come up. And during those first 2 weeks that patients are new members on the team, we really do a thorough workup about their organs. So as we talked about, it's important to have healthy lungs. So we do pulmonary function tests, we do echocardiograms, we take several different types of blood markers to make sure livers and kidneys and all those things look okay. We look at any dental issues, if people have any issues or cavities, or it could be a breeding ground for infection. And most centers do have some amount of formal educational classes that they send the patient and caregiver to. And some centers, this is done kind of informally. And then your team will determine which treatment regimen is best for you. And again, we have a plan in mind when patients first arrive. Depending on the workup and how things are with the donor, that plan may change. So, if we're working you up for an unrelated donor and in their workup, their team finds something that is a challenge to being a donor, then maybe we change course and look at a cord blood unit or something like that. So it happens. And then your team also often talks to you about what will be the projected length of hospital stay if they are projecting a hospital stay. Our center, and I don't know how many other, I think several other centers do this, do have a fair amount of like reduced intensity transplants that we try to do on an outpatient setting. So that's nice that we plan to keep people outpatient on some of these regimens. So simultaneously, while we're working you up on the transplant team, someone in that medical center is also obtaining medical clearance. So they're looking at, is your insurance clearing you for this regimen, for this protocol? If it's a investigational protocol, sometimes that gets a little stickier. We also educate you about the regimen that was selected for you and the side effects, and information about the immunosuppressive medications you will receive. So graft versus host disease, we'll talk about a little bit more, but something that we use to quiet graft versus host disease down are immunosuppressive medications. We'll place a central venous catheter, which you'll see pictures of a little bit later, and teach you how to take care of that. And then finally, we will begin the chemotherapy or radiation, or in some cases, people get both. So I know this picture is probably not something you want to see at lunchtime, so sorry about that, but I always think it's important for people to see, what does a central venous catheter look like? This one is a little bit shorter than most of the ones we use, but we do use this line sometimes in our center. So when it's placed, it's external, and these parts you see coming out of the chest will be external the entire time the line is in place. So it's similar to a PICC in that if you've ever had a PICC line, and that parts of it will always be external. So we teach patients how to take care of it, how to protect it for showers. We don't want water getting in to the insertion site or through the caps. These need to be flushed daily. So we teach either you or your caregiver how to flush it. At some centers, they have the patients coming in every day for flushes. And then this is a long-term line. So this line is intended to be in place for several months. So if your doctor and your medical team have instructed you that you will likely be going into the hospital for your entire regimen or for some part of it, people often ask, what should I pack? I think this is really important right now, especially at a time when people are feeling isolated and maybe limited in the amount of people who can come visit them in the hospital. So pack things that remind you of your home. Do you have a favorite pillow? Do you have a favorite blanket? You can bring a computer, puzzles, magazines, coloring books. You probably noticed I left off reading books. That's something that people can bring, but obviously once people are on chemotherapy or receiving anti-nausea medications, many people find it hard to concentrate on something that long. So something that doesn't require quite as much concentration tends to be a little bit easier. Do not bring anything of value. I think in general, hospitals are pretty tight with security, but just in case, obviously things have happened. Don't bring any of your medications unless your team specifically tells you to. And as we touched on, no plants and flowers. So when you're in the hospital, the majority of the day, you'll be hooked up to an IV pump, getting medications. Most transplant centers have private rooms. There's Wi-Fi, there's cable, there's usually DVD players, although I'm aging myself a little bit when I say that. I think that the way of the future is now just streaming and Wi-Fi, but I think there's still some dinosaurs out there that, like myself, that watch DVDs. Your nurse will check on you, or medical assistant will check on you about every 1 to 2 hours. And oh, something got left off the slide here, sorry. So some centers right now are allowing 1 visitor, and some centers are allowing no visitors because of COVID. Some are allowing 1 visitor, but it needs to be the same visitor during that entire hospital stay. So for instance, your daughter couldn't come visit you today, and then your son tomorrow. So just make sure that you are aware of the precautions. Daily shower, and that is in order to keep the bacteria count on your skin down, and a daily walk. And that is a really great way to keep your lungs healthy and keep fluid circulating throughout the body to prevent any fluid accumulation. And as we touched on, no fresh flowers. So there's well-meaning people in our lives that do want to send us flowers because they care. And here are some alternatives. So they can send balloons, they can send socks, cards, stuffed animals, any type of unscented creams. So those are some other things they can send. So this is less of an issue right now because, as I said, most at least part of hospitals are not allowing a whole lot of caregivers to come in the hospital. But when this changes, it's a really great time for your caregiver to take a break. So obviously I've seen caregivers that have a hard time leaving the bedside of their loved one when they're in the hospital, which I understand, most of us understand. But when that patient, when you are out of the hospital, we expect you to hit the ground running and being 100% available. So it's a really great time for the caregiver to take care of themselves and do all the outstanding things in their lives so they can focus on the patient when the time comes. So every hospital and team has different criteria for discharging transplant patients, but this is our criteria in Seattle. So our patients have to be eating and drinking fairly well. They, for the most part, have to have some amount of a neutrophil count, which is our infection fighting white blood cells. They have to be able to take all medications by mouth, or most, have minimal side effects, be fever-free, be able to safely ambulate. For instance, if we have someone who is only able to transfer to a wheelchair and not able to stand or walk, that is not an appropriate person to be at home because they wouldn't be able to find someone to take care of them. And then they need a full-time caregiver. So common side effects immediately after transplant: nausea, vomiting, diarrhea, mouth sores, bleeding, elevated risk for infection, fevers, muscle weakness, skin rash, fatigue, and as we touched on, hair loss. So nausea and vomiting, my whole career have spent a significant amount of time educating patients about how to take anti-nausea medications because they're really confusing. So I would say the first thing to do is be familiar with your anti-nausea medications. And also understand that different anti-nausea medications may work best for you. And lack of food or too much food often triggers nausea. So it's not uncommon for our patients to have nausea first thing in the morning because they don't have any food in their stomach, or nausea after they've overdone it eating a very large dinner. Our best way to help prevent nausea is to take it the minute you feel nauseated at all, don't wait and say, gosh, maybe it will pass, because it's oftentimes really difficult to stop the train once it's already left. And then I encourage patients to keep a food and fluid log, and that just helps you determine, are there certain foods or times a day that are triggering nausea for you? Most people, if they get nauseated in the morning, it can be because they tend to have a large amount of pills they take in the morning, or they ate something particularly spicy. So I would encourage people to keep tabs on that. That's another great thing to delegate to the caregiver. Diarrhea and constipation. Diarrhea is more common, but constipation also happens. And same as before, I would encourage people to keep track of their input and output and just make sure how balanced their fluid status is. And just see if there's any diet modifications and reporting any changes to the team. And there are some medications that may contribute to this. For instance, if any of you have had Zofran, you may know it can cause constipation, also may cause some significant headaches, but there are some medications that can cause diarrhea or constipation. Mucositis or mouth sores is another common one. So we encourage our patients to participate in saline rinses, which your center, your nurse, your medical assistant can teach you how to make. Avoiding dry mouth, frequent oral assessments. So the team will look in your mouth and see if there's any signs of infection or bleeding. And then people are really surprised when they hear that our center advocates for continued toothbrushing and flossing, even when people have low counts. And that's just if there's no bleeding or no pain. So, and this is just a soft bristled toothbrush, nothing too intense. And then no over-the-counter mouthwashes, as they can be extremely drying. So cancer-related fatigue is a real issue. And I will say this can be present at any time during the transplant and tends to be one of the last side effects that goes away. So I really like this definition from the NCCN, National Comprehensive Cancer Network. It's a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness that is related to cancer treatment that is not proportional to recent activity and interferes with usual functioning. And it also, their definition says that it's not does not improve with rest. So our ways to fight fatigue is we look at, are there any contributing medical factors? Some medications can make people pretty sedated and sleepy. Making sure people are exercising as much as tolerated. It seems counterintuitive, but a recent study out of our center found that even 20 minutes of activity a day combated fatigue by about 34%. So it's pretty staggering how much keeping active, even when you don't feel like it, really does help fight fatigue. And it keeps your lungs happy too. Taking rest periods when needed, trying to de-stress your life in whatever ways possible. And I understand life doesn't stop when you're going through cancer treatment. So sometimes there's not much you can do about it, and people do have other stressors in their lives, but reducing stress when they can. And that can include whatever things have tended to help you relax in the past, whether it's yoga or imagery or music or painting, whatever those things are. And then also our nutritionists can offer advice. A well-balanced diet also helps contribute to combating fatigue. Sorry, my screen keeps wanting to go back a slide. So sexual health is something that is very underassessed in the oncology and transplant setting. It's really unfortunate. I think it should be something that we're talking about along with mental health every clinic visit, especially as people are recovering from transplant, because it is a really important part of our relationship. And I don't just mean, sexual interactions with your partner. I mean, even like intimacy, finding a way to be there with your partner. And it can be a challenge. And I've heard of frustrations from both the patient and caregiver in my career. So just know it's really normal. Depending on what your counts are, it usually is okay once your platelet count is above a certain level and your white blood cell is above a certain level, to participate in sexual intercourse. And people may have some challenges with lack of desire and sexual dysfunction, and that's okay. But certainly I want to encourage you to bring this up to your team. There may be body image concerns. People may feel like they look different, that their partner may have not find them attractive. So we encourage patients to communicate with their team, communicate with their loved ones, and also try to think of other forms of intimacy during this time. Can you cuddle on the couch together? And some of these things are really important. So now that patients are out of the hospital or recovering from their transplant, what are big things we're looking for in addition to the side effects we mentioned? So a big one is graft versus host disease. And that is your cells that we've transfused attacking your body and recognizing that as foreign. And then different types of infections. So bacterial, viral, or fungal, any organ dysfunction related to treatment. And we are also looking for any signs of disease. So graft versus host disease, it's a systemic inflammatory condition mediated by the transplanted immune system that can lead to multi-organ failure. Acute graft versus host disease occurs in the first 3 months post-transplant, and chronic usually occurs after the first 3 months. So in some cases, as people are getting around 2.5, 3 months post-transplant, they may have some acute graft versus host disease and some chronic. And we differentiate because the mechanism between each type is different. So they have very different side effects. For instance, skin graft versus host disease occurs in both acute or chronic, or can. But in acute graft versus host disease, it's manifested as a skin rash or raised rash. It can be pretty significant. It can be really uncomfortable. It can cover the entire body or just be one small area. And then chronic skin graft versus host disease, more is skin tightening and decrease in range and motion, more like a scleroderma. So they're very different. So just thought I would point that out. This is really interesting to me, and some pretty recent studies in the last couple of years, that your gastrointestinal microbiome is really, we're finding out, plays a significant role in shaping the mucosal immune system, and therefore does have an impact on graft versus host disease. So meaning some of our patients that are diagnosed with graft versus host disease in their intestines or stomach, oftentimes we do see a lack of diversity, and many centers are doing studies to look at how we can improve this, and looking at the multi-million-dollar question, which is, if someone has lack of diversity in their microbiome, is this something we can modify, or is this something they're born with and potentially a little bit of a risk factor? So, and nobody knows the answer to that question yet, but kind of new information hot off the press. So in your clinic visits, we're going to be looking for graft versus host disease, seeing how eating and drinking is going, seeing if there's any issues with diarrhea. Another area acute graft versus host disease goes is the liver. So we would pick that up on liver function tests. Excuse me. Chronic graft versus host disease may also impact the lungs. So we'll be looking closely once you're about 3 months post-transplant or 6 months at pulmonary function test, and looking at skin, doing a range of motion, seeing if you have any signs of the scleroderma we mentioned. So first line of treatment for graft versus host disease is steroids or a change in immune suppression. And then a second line of treatment may be available, actually is available if there's no response to the first line of treatment. And I see some questions here, and I'll look at them when we're done and we can talk about them. Other post-transplant complications, infection. So the entire time you are on immunosuppressants, you are at risk for fungal, bacterial, or viral infections. The normal bacteria in your gut and on your skin are major sources of infection post-transplant. So this is why it's so important that we also you're taking your daily showers and teach you how to take care of that central line in an appropriate way. And then why it's so critical that you or your caregiver report any sign of infection to us is that we want to intervene as quickly as possible and may need to start medications in some scenarios. And just making sure you're taking antibiotics, antivirals, and antifungals as the team has prescribed. So at our center, patients are on their allo transplant teams until about day 100 post-transplant. We see our patients a minimum of 1 to 2 times a week. You may, in our center, may need to remain on the transplant center more than 100 days if you still require fairly close monitoring, as some home oncologists don't have the bandwidth to see you twice a week in clinic. And then your team, the medical team and caregivers will be looking closely for any of the side effects we mentioned. Excuse me. And then around day 80 post-transplant, we start to repeat the process to look at your organ function, see if there's any sign of disease, and get you ready to go back to the oncologist that you came to us from. So the last tips for recovery I have is to be patient with yourself, exercise or try to move your body daily, adhere to the medical plan that the team has outlined, rest when you can, protect yourself from the sun, exposure to sun, too much exposure to sun or sunburn has been known to activate graft versus host disease. So something that your team will be spending more time talking about. And like I touched on earlier when we talked about sexual health, is mental health is another thing we're getting better at talking about with our patients, but there's still room to improve. So making sure that you're reaching out to your team if you're having any challenges with anxiety or depression, could be related to the disease. Sometimes some of the medications may cause some of these feelings. So just try to be as open with your team, and we can always look at if there's things we can do to help out. These are other resources. There's a wealth of information on all these sites. So there's the AAMDS Foundation, as you know, which we're part of today. There's BMT InfoNet. There's Be the Match, which is the same resource we mentioned early in the presentation, where you can look at transplant center numbers and outcomes. Leukemia and Lymphoma Society. There's the National Bone Marrow Transplant link as another source of information. And then just a final reminder for you, when you find yourself doubting how far you can go, just remember how far you have come, and remember everything you have faced, all the battles you have won, and all the fears you have overcome. So transplant is a really uncertain time in people's lives, especially now with COVID. So just give yourself the grace to know that it's normal, and your team is there for you, your caregiver is there for you. And I think that's all I have for you today. Are there any, I'll get to the questions in the chat first.
Hi,
So I'll
Costa.
Hi.
Hi. Okay, I will get started with some of the questions. So our first question is, what is the average time of hospital stay for a BMT? for someone who is either below or under 50?
That's a really good question. It depends on the regimen your team has outlined for you and what they feel is best. And if you have any other medical issues, in general, if your team has decided that you need to go into the hospital to receive your chemotherapy, receive your stem cells, and remain there until you recover, it's on average about a 28-day hospital stay.
Thank you. There was a question about fatigue. Wanted to know if you could go over fatigue again and put up the slide that you had.
Oh, sure. See if I can find it again. Here's the $1 million question. Yeah, it's really can be pretty long lasting post-transplant. So, okay, one moment. Okay, so here's the definition, which I think is important to touch on again. It's not this feeling of like, oh, I just didn't sleep well. It's this, I've been resting, I'm sleeping well, and I still feel incredibly exhausted. And so our biggest things, and as I mentioned, several studies out of Fred Hutch did show the importance of daily exercise and how it combats fatigue, but also making sure that people are breaking up their activity. So for instance, I always tell my patients, so if your goals for the day when you're out of the hospital are to walk with your family, go to the clinic, shower, I would not do them all in a row, especially as you're recovering. So I would take your shower, sit and relax, rest a little bit, see how you're doing, and then get up a bit later, take your walk, and then so stagger things. And that really helps as well. I also just had a patient I saw last week that was out of the hospital. He was so excited to be out of the hospital. And prior to that had been walking many miles every day. So his first day out of the hospital, he decided to walk 3 miles. And I commended his enthusiasm and endurance, but he really felt pretty crummy the next couple of days after that. So I would say build back up to activity. Certainly we mentioned exercising 20 to 30 minutes a day, even a brisk walk or a ride on a stationary bike, but build up to that. I wouldn't say you have to start at 20 minutes. And then nutrition does really seem to play a key role in fighting fatigue. So the more diverse the amount of nutrients and electrolytes in the food you eat, the less issues with fatigue you'll have. So I'm not sure if that answered your question. Was there another part of it?
Yes, there was another fatigue question, and it says, what are your thoughts about medications such as Adderall for patients with profound fatigue?
I haven't heard of that one. I haven't heard of that being used at our center. So I have just my background as a nurse, knowing, what Adderall can do in children. I would say, obviously listen to your team and the guidance of your team. But I would say these methods we have up on the slide are kind of the gold standard and probably going to be more easier to attain. The other thing is many of our patients post-transplant are taking upwards of 30 pills a day. And usually the last thing people want to do is take another pill. They're begging me every week, what can we take off? What can we get rid of on the med list? So that's something to keep in mind too.
Thank you.
Yeah.
Our next questions are regarding patients older and around 70. How do those patients fare in transplant? Are there any special risk or special precautions for patients who are in their 70s?
Great question. So every 70-year-old health-wise is not equal, just like every 40-year-old is not equal health-wise. So the first point is that our patients that are in their 70s generally are in fairly, they generally don't have a whole list of other medical complications and issues they're having. Because as we mentioned, it can be hard on your liver, hard on your lungs, hard on your heart. So if you already have issues with those body organs, it may not necessarily be the best fit depending on how severe those issues are. That being said, we have, I saw 2 patients yesterday in their 70s. What we do is we give a reduced intensity chemotherapy, at least in our center. And I've actually had several of them who never went into the hospital at all. So, we don't really think of age per se when we look at transplant. Certainly it's in the equation, but the bigger issue is what are the other health concerns? What is this person bringing to the table? And that's true of someone in their 40s as well. If someone in their 40s has a whole laundry list of health concerns, transplant may not benefit them because it could harm them more than it would help them. So same is true of someone who is in their 70s.
Thank you. So age really now isn't so much a factor. So patients who are in their 70s would be eligible for a transplant. It's more based upon how you are medically. Is that correct?
Yeah, and the disease and, there's all kinds of factors that go into, at the end of the day, when all of us went into medicine, we all take oaths to not do any harm, right? So if we look at you as a patient and we think we would do you more harm than help with this treatment, that is when we would say transplant's not appropriate. But that's individualized for everybody.
Thank you. Are prophylactic penicillin, is that prescribed for post-transplant hyposplenism?
Usually, yes, it is most of the time.
Thank you. And are there certain tests that are run to ensure that a patient is healthy enough to undergo a transplant? And I know that can be center by center, but is there like a gold standard of tests that are done to ensure the best anyone can that a patient is healthy enough for transplant?
Absolutely. So when our patients enter our system, within the first 2 weeks they're there, we do pulmonary function tests to look at their lungs. We do an EKG. And if there are any concerns we have on the EKG, then we look further into their heart, whether that's sending them to cardiology or having a treadmill stress test, whatever the case is. We look at your disease status. So we usually repeat a bone marrow or PET scan or however your particular disease is staged. Liver and lungs, we look not lungs, liver and kidney, we look at blood work to tell us how they're functioning. Sometimes we do urine studies to see how people's kidneys are functioning. We look at any other issues. For instance, if people have like some type of rheumatology disease or things like that, we look at, are they stable? We would send them to rheumatology. So sometimes part of the workup where we're evaluating their body and their organs, and there's a question mark at the end of that test, then it requires another referral. So if we do your pulmonary function test and there's something that seems a little bit off, it's very common that we could send you to the pulmonary team to ask them to weigh in.
Thank you. And our next question is, and do you know the percentage of patients who don't get graft versus host disease, and is it related to the HLA match?
So graft versus host disease is related to the HLA match. It is also related to the donor source. So peripheral blood stem cells, which is what we're largely doing right now, does tend to have a little bit more graft versus host disease. Umbilical cord and bone marrow tends to have a little bit less, but they present different risks. And yes, so a perfect match, which means, so back to HLA matching, we're usually matching patients on 10 or 12 alleles on their cells. And most centers will not perform a transplant if someone is matched lower than 8 or 9 out of 10, because it's just frankly pretty dangerous. And those, if they're the two types of HLA markers are so different, they're just gonna not play in the sandbox nicely. So yes, it is definitely dependent on donors. And I would say that on average, we tell our patients about 60 to 70 may experience some form of graft versus host disease. So that may include, as I mentioned, just a little skin rash on one arm that we biopsy and confirm it's graft versus host disease. It may be just a little bit of an upset stomach or lack of appetite, or it may be something more severe. But I would say it's 60 to 70. But what we have done, so I've been in transplant about 19, 20 years, is we have made a significant amount of progress in improving our outcomes with grade 4 graft versus host disease. So even our patients that get graft versus host disease don't tend to be as sick as they were 15, 17 years ago. So.
Thank you. Are pre-transplant and post-transplant antibiotics given? And the second part to that is there a standard of those antibiotics that are given, or is it center by center?
You know, I'm not sure what other centers do with their antibiotics. Our center, what we do is we have patients on antibiotics for several weeks before they start their conditioning. And then as they start their conditioning, we take them off antibiotics and then put them on as needed after transplant. So not necessarily the whole time. But again, I don't know what other centers are doing.
Thank you. Our next question is, do haploid transplants have a higher risk of graft versus host disease?
They do a little bit, but it also is a very viable option who wouldn't have, if someone wouldn't have had a donor source otherwise. So haplo is a half match. So that means we're replacing half of your cells with someone that's half matched to you. So it could be a parent or a child, because both of those people are half matched to you. But since we're not completely obliterating your own bone marrow, there's obviously more risk of graft versus host disease. But again, you know, if this is the only option we have and people are otherwise healthy, it's still less of a risk than letting whatever disease process take over. Sometimes it depends. Again, every patient's so different, but those are all decisions that go into what's the best transplant for you.
Thank you. And our last question is, does having an autoimmune disease cause worse GVHD?
You know, it's really interesting. I have seen it cause a flare. I've also seen it become less of an issue with transplant, because if you look at it, there was something not correct with the immune system that by replacing your immune system with a different immune system, we've resolved. That being said, if there's any underlying autoimmune issue, once we give patients immunosuppression, we've also seen flares of that autoimmune. So really, we've seen it go both ways. In every transplant course, this is something I didn't mention, but is really important to mention. Every transplant course is very different. Even if everything else on paper is the same with someone else, you're the same age, same disease, your courses will not be the same. So it's really hard, and each plan is individualized for each patient.
Thank you so much, Costa, for spending your time and your expertise with all of us today. And if you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820 extension 2, or submit your question to our Facebook page. On behalf of the foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 37 years. This concludes our program. Thank you again.
Thank you so much for having me. Have a great day, everyone.
Have a good day.
Bye.